All right, good to know. Okay, so I'm one of the physiatrists or rehab physicians at KU. And so I work primarily on the main campus and see a lot of patients in consultation acutely after their stroke and help them get to the right place for their rehab needs, which I like to think is KU rehab. And then I do have clinic throughout the week in which I follow patients longitudinally. So typically after they've completed their acute rehab course and hopefully discharge successfully to the community and still have rehab goals, because rehab never really ends. We're always trying to improve and get better. And regardless of what level we're at functionally, there are things that we can work on. So with that said, today we'll just kind of a very high level overview of post-stroke equipment, devices, anything from bracing to wheelchairs to durable medical equipment, and then just kind of a brief discussion about some of the things that are on the horizon as well. Okay, so typically what we're trying to address when we're talking about post-stroke device management or usage is trying to both compensate for as well as augment our level of function. And so typically after stroke, as we know, we're dealing with what's called symptoms of the upper motor neuron syndrome. So typically that's weakness, as well as spasticity, as well as numbness, lack of sensation, so on and so forth. But really what we're trying to accomplish is, like I said, to compensate for that weakness, to address some of the corresponding neurologic impairments. And so when we have a stroke, and typically patients that are having strokes are a little bit older as far as the age of onset, and so we're also dealing with other medical issues. So as we get older, arthritis tends to be more common. Alongside with the stroke, we tend to be less active, and we can get deconditioned. We can gain weight associated with the stroke itself. We can have pain, centrally as a result of the neurologic insult, as well as pain from the musculoskeletal conditions that we talk about above, weakness, spasticity, and that can unfortunately progress to contractures. And so let's talk about orthotics first of all. Okay, and so what is an orthosis? Well, it's really a generic term for any type of device that we use to modify and enhance the function of our musculoskeletal system. So orthosis, orthotic, kind of interchangeable terms. Orthotic, that term typically is reserved for shoe inserts. Orthosis is what we prefer to use as far as the term. I'm just getting into the semantics here, but what are the goals of using an orthosis? Well, number one, if nothing else, we want to make sure that things aren't getting worse, regardless of the issue that we're addressing. So we want to provide protection to the specific body part or joint that's affected. We want to correct or modify any kind of malalignment that could be occurring as a result of stroke or corresponding weakness. And then ultimately, as a rehab doc, I'm concerned with function. That's probably the word I use most in my practice is function. What's your current level of function? What's your level of function that you hope to achieve? And then what kind of, in this case, device can we use to enhance function? Okay, and so these are just general principles of orthoses, regardless of what we're talking about, whether it's for the hand, shoulder, knee, foot, ankle. These kind of general guidelines apply. So number one, we need to make sure that we're getting a proper fit and that it's comfortable for the patient to use. Otherwise, this is just going to go in the closet, and that's not going to do anybody any good. So we really rely on our partners. At KU, we use, and by the way, I don't have any financial interest in any of the products I'm talking about today. So I'm not trying to steer you in any directions, but with that said, when it comes to proper fit, comfort, and really, we write the initial prescription as physicians, but when it comes to the actual fulfillment of that prescription and really the customization of that order, we rely on our prosthetists and orthotists in this case. So we commonly use the folks over at Hanger. They have a location near our main campus, right below our rehab hospital. So, physicians are important, but really the orthotist in this case is going to be your best friend, and then the therapist as well, who are going to actually get to see you use it in action. And so it's a team effort. So proper fit, comfort, cosmesis for a lot of our folks. Similarly, if it's not looking good, it's going to end up in the closet, and that's not really going to help anybody. Ability to don and doff, so put on, put off, or take off, I should say. So, if this is entirely cumbersome, depending on the orthotic or brace, we can use that term. Again, it's going to potentially negatively impact whether our patients are using it. And then ultimately, we want to make sure that we're improving function, we're not limiting any existing range of motion, and so we can hopefully achieve our functional goals. Again, all comes back to function. Okay, so generally when we're talking about orthotics or orthoses, two broad categories. So static, as this gentleman here in the recliner illustrates, no motion is allowed in that type of brace. Okay, we'll go through examples of these as well. And then dynamic, which will allow range of motion. And again, one of the general principles, we don't want to limit any range of motion that we do have. We don't want to exacerbate the problem of potentially developing joint contractures that can lead to pain and really impair our ability to use that affected joint or limb. Okay, so we'll go upper extremity down to lower extremity. We find that upper extremity orthoses typically more useful for patients who've had an increase in their muscle tone after stroke. That being said, there is typically in the initial post-stroke period low tone, so where our limbs are really weak and flaccid, and so we can use our bracing in either scenario. So typically in that initial post-stroke period, we're using positioning orthoses. We're trying to prevent dislocations, contractures, swelling, and pain. And so for patients that may be on the lower end of the functional spectrum after that initial stroke, sometimes we'll make modifications to either their seating wheelchair device with a lap board, for example, to try and maintain positioning as it should be occurring naturally. And then here we have just an augmentative wheelchair device to support, in this case, hemiparetic right arm. Okay, so we'll talk about slings in particular. I want to focus on the things that if you come into my clinic, we're more likely to discuss and hopefully more likely to get you. So I guess I should preface this by saying post-stroke shoulder pain is very common. I'm sure this is something that a lot of you have experienced. The prevalence of it is up to 60% of post-stroke patients will experience some post-stroke shoulder pain. And the reason for that, well, there's a lot of different potential reasons, but the most common is that as our muscles on the stroke-affected side get weak, particularly when it comes to the shoulder joint, we really rely on our muscles and our tendons to maintain the anatomical structure of that joint. So we have the head of the humerus that's fitting into the socket in the scapula. And so those tendons make up the rotator cuff. As the rotator cuff muscles and tendons weaken, it's very easy for the head of the humerus to what's called sublux, or basically dislodge essentially from the proper anatomical position. And so that can cause a lot of pain. That's just one cause. We can also have what we call bursitis. We can have arthritis, like we talked about. A lot of patients have some underlying arthritis, and then this can exacerbate that. So when we talk about arm slings, we're trying to address pain a lot of the time more so than function. So this is one circumstance where function is not at the top of the list necessarily. That being said, we don't want to cause any problems that further down the line could impact our function negatively. So positive benefits of using slings: they're relatively cheap, easy to use for the most part. They're lightweight, they're portable, so getting them on and off. Some are trickier than others, but generally not going to be an issue. Okay. This right here is what we call an envelope sling. This is not typically something that we like to use. A lot of times after stroke, we have what we call a flexion synergy in our upper extremities. Basically, it's very common for our shoulder and arm to be internally rotated, flexed, okay? And so if we're using a sling like this, we're further contributing to that positioning. So this is something that we could use in the very short term, but not something down the line that we'd like our patients to use. And so this is the sling that I'm most commonly using for patients who are having a lot of pain with that hemiplegic shoulder. And by the way, there's obviously other interventions and treatments that we can use for pain, but this, when correcting the anatomy, is a good way to go. And so this type of sling, as you see here, a more natural anatomical position. And so this harness is going to help hopefully reapproximate, or will reapproximate, by using traction, putting that head of the humerus back into the shoulder joint. This particular type of anatomical position is actually going to make it easier for arm swing through our gait. So even though it's addressing shoulder pain, it will actually enable us to walk a little bit more fluidly, if that's also something that we're struggling with. Like I said, the cost of these are relatively cheap and affordable. $70. There is a learning curve as far as how to put these on, but your therapist, if you're working with them, can help you, as well as the orthotist can help you learn how to take these on and off. And usually people can do this individually. What you will see here, though, is because of the way that the orthotic is essentially strapped in around the hand and the elbow, we're not going to have as much functional use of the arm. Okay. And so that's where something like a humeral cuff may come in handy if we just happen to have pain in the shoulder and we want to reapproximate that joint. This is just one type. There are multiple different types, some that look a little bit more cosmetically appealing. But as you can see here, we still have the ability to flex and extend at the elbow, and we don't have anything on the hand. So this is going to help with some of that post-stroke shoulder pain, but still enable us to be functional with the remainder of the limb. Okay. All right. Spasticity is a big part of my practice. It's probably the most common reason that we're using orthoses in the acute phase after stroke. And so these are just two examples of ways that we can use proper positioning. And again, this is just one part of a really complex equation where we're talking about stretching with therapy, medications, potentially interventional options like Botox. But essentially, this is just one example of a static type of splint, right? So we don't really have any range of motion. We're just putting this on and staying in this fixed position. And then this is a dynamic splint. It's actually called a progressive splint, and that we can modify this as our spasticity hopefully improves over time and lessens. We can actually adjust the angles of these on particular joints as far as how these are used. This is another type of more dynamic splint. As you can see, this is also helping to address tightness and spasticity at the elbow joint as well. And really, it's cumbersome, but if spasticity and pain related to that is an issue, this is nice because we can adjust the tension at just about every joint here. So we have our interphalangeal joints in the hand. We have adjustable tension at the wrist, as well as the forearm and the elbow as well. Okay. So those are really, that's just kind of a high level overview of some of the things we use. Again, post-stroke shoulder pain, some of these slings that can reapproximate the humerus into the shoulder joint have really been beneficial for our patients. Okay. All right. So we'll move on to lower limb. And so probably, functionally, what's most important to a lot of our patients is mobility, our ability to walk, our ability to transfer. And so that's where these orthoses can really come in handy. And some general principles for all orthoses, but here in the context of lower limb, we only want to use these for as long as we need to. We want to allow natural joint movement to occur. We never want to inhibit natural movement and strength. We don't want to make our patients weaker. And then lastly, we obviously want this to be useful throughout all phases of gait. Okay. So AFOs, most commonly prescribed orthoses in my clinic for the lower extremity, comes in a large variety of shapes, sizes, materials. So we'll talk about some of this briefly today. Typically, we're talking about two materials, metal, plastic. This is kind of plastic with a leather strap. And so what we typically want to address with the use of these is foot drop. So that inability to lift the foot off the floor when we're walking. If that toe is dragging, then we want to be able to use a relatively, non-cumbersome brace so that patients can walk without risk of tripping and falling. Okay, and so what I'm getting at here, as far as wanting to stabilize the knee during gait, is that like the old kid nursery rhyme, the hip bone's connected to the knee bone, and so on and so forth. Our gait is it's all interdependent on the joints throughout the body. So even if we're just addressing the foot ankle, it's going to affect the knee, it's going to affect the hip. And so that's something we need to be mindful of when we have patients that are trialing these. Okay, so just to go over some AFOs briefly. Metal AFO, this is kind of the grandfather of AFOs, if you will. Not typically something that patients want to use as heavy metal brace. This actually inserts into the sole of the shoe itself. Really, this is for patients who can't tolerate something directly on the skin. If they have a lot of pain, neuropathic pain or musculoskeletal pain in that limb, and they can't tolerate having a brace actually fitted to conform around the joint, then this will be useful because it doesn't touch the leg. And so similarly, in other conditions where we don't want the brace to touch the leg, such as wounds or really considerable edema and swelling, this could be an option. This is a more commonly prescribed AFO. This is a lightweight thermoplastic. You can see how thin it is. It can fit in your existing shoes, so you don't need to wear something like this. You can put this in any kind of sneaker. What's nice with this thermoplastic material, you can buy it prefabricated to make it a little bit less costly. And then if you see your orthotist, they can actually mold this. You can just heat up the plastic and really make it fit a little bit better for you. And so these are really a good option for patients who are on the higher end of the functional scale, but they do have some foot drop. As you can see, there's really not a whole lot of medial, lateral, or any ankle stability whatsoever. So in that case, we'll use something a little bit differently cut so that you do get some medial lateral ankle support. Okay, so these are both what we call thermoplastic AFOs, and as is this. If our patient does have the ability to what we call dorsiflex the foot, so if you're looking at your foot, you kind of cocking your foot up at the ankle, that's what we call dorsiflexion. So how I mentioned earlier, we don't want to impede strength that we have. This joint will allow us to maintain the strength that we actually do have. And so for patients who do have some strength, they don't have kind of an overt foot drop, but they just have foot weakness, this is sometimes a good option for them. And then going into a different material, carbon fiber, this is probably, I'd say, the more cosmetically appealing for a lot of our patients. It's super lightweight, which is great. It also is going to give you some kind of a dynamic response. By that I mean like a spring type of action, so that it's actually going to provide some compensation for some of the weaker muscles that we have. Because it is carbon fiber, it's not as easily moldable, and so for that reason, you know, you have to make sure you get a good fit at the outset. Okay. All right, so now on to assistive devices. Okay, so basic premise behind any kind of assistive device, as you might imagine, is really to improve our stability. In particular, we want to widen the base of support. So if we have our feet really closely together as we're standing, it's really easy to tip over, right? And that's because we just have this tiny, narrow base of support. So we have a wider base stance, we have an increased base of support. And so you don't need me to tell you, wider base of support, it's harder to fall over, right? That's why you do this naturally in a lot of cases. And additionally, you're able to redistribute weight over a larger area. And so that can often reduce pain on an affected limb, okay? And we can widen that base of support even further with assistive devices and gait aids. So single point cane. This is what we call lost strand crutches. These are traditional crutches, which you're probably not going to use, but you get the basic premise. And then this is even more so when we're talking about using a walker, right? We have an even greater base of support and less chance of falling. Okay, so for those folks who use canes, you know, it's not uncommon to see patients come in and been using a cane for years and years, but they've been doing it wrong, at least according to the textbook. The right answer is, you know, whatever works for the patient and achieving their function is the right way to do it. But typically, how we want patients to use canes, we want the height to go up to what's called the greater trochanter. So that's kind of that bony prominence on the lateral leg that you can feel. So this is often a lot lower than patients you know, have their canes measured. We want our angle to be at 15 to 20 degrees. So this is going to be uncomfortable and cause some problems over time, as is this. Okay, so it's important that we're flexed, but not so much so that it's going to cause joint problems and pain. This is going to be used typically on the unaffected, so on the strong side. Okay. All right, and so as we progress to walkers, I guess we should say before we even get to walkers, we have hemi walkers. So these are something that, you know, actually a lot of patients don't know about, but can be really useful. This probably isn't the best representation of them. Some of them are a little bit, they actually are a little bit easier to maneuver, and some have wheels. But it's nice when you kind of need that in between a cane and a full walker. Okay. And when we talk about walkers, there's two types of walkers generally. There's four-wheeled walkers, and then this is a traditional front-wheeled walker. So if you use this, you're going to have to lift so that you're only relying on the wheels to propel yourself as well as yourself, obviously, as you move forward and ambulate. And then if you need to stop, you can just abruptly drop these two prongs here, these two ends of the walker, so that you don't risk falling at that point. And so this is good for someone who doesn't have the ability necessarily with a four-wheeled walker. I guess I should say, if there's risk of that walker getting out in front of them to where they're kind of catching up and could potentially fall. So this is a more conservative type of walker. And then as you progress to a four-wheeled walker, you can do that. And a lot of times you'll see the four-wheeled walkers with brake activating systems, so that you can either press on the brake to stop, or there's reverse ones where you can press to propel forward. And then as you relax, the walker is going to automatically stop. Sometimes you'll see walkers with benches on them as well, or just little seats. These are typically foldable walkers, and those are good options in that they're more transportable. You can just fold them up, put them in your car, and then depending on where you're going to be in the community, if you're going for a longer walk, for example, then you can just put that seat down. I'm sorry, I don't have a picture of it. and you can rest until you're ready to keep moving. Okay. Low strain crutches. So as opposed to traditional underarm crutches, these are nicer in that less pressure irritation. We have this forearm cuff you're able to lean on so that you can use the hand to use other activities. So you can still propel your support your weight and use your hands freely. Okay, and it's also typically a good type of orthotic for patients who have pain in their wrists and hands. As far as other just kind of around the house type of devices that you can use, these three are in the category of extenders. So you can use for combing your hair, for example, if you have difficulty as far as your shoulder range of motion. You can use reachers to pick up items around the house, either above or below, and then sock aids. Lower extremity dressing is really difficult for a lot of our patients, so this is just one type of tool that you can use. And then for patients that are having fine motor impairment in their hands, there's some different types of build-up handles for things like utensils, as well as key holders and things like that. So these are all readily available online and cheap. For patients who really don't have any movement and fine motor dexterity in their hand, they can use what's called a universal cuff. And this just slides over the hand, and then you can put in different objects to manipulate with the strength that you do have in your proximal muscles. And then these are things that you can also do around the house here. I'm sure you've seen these tub transfer benches. Given the height of the tub, it's really difficult for a lot of our patients to get in and out if they don't have a walk-in shower. And this is often the best compensation for it. This is a shower chair if we're unable to stand in the shower for longer periods of time. Grab bars, toilet risers. This is a sit-to-stand lift chair. Actually, I have a lot of patients asking me about this because wouldn't it be great to have insurance cover our new lazy boy? And it would, but unfortunately, insurance will only pay for this portion of the device, so the actual lift mechanism. So it's unfortunate. The chair itself is going to run you like, $800, we'll say, and then this device itself is probably only, I don't know, $150 or so. So you're still on the hook for the remainder of that amount. Unfortunately. But it can be a good option if you have the means. Proximal muscle weakness, like we talked about earlier, is we have a stroke, we get weak, we get deconditioned. A lot of our folks spend an awful lot of time in their recliners, and it can make it difficult for them to actually get up and transfer. Okay, let's talk about wheelchairs. I'm not going to go into all the details here, but essentially just wanted to emphasize just how many components of a wheelchair there are that we're not even really thinking about. Typically, for people who are uninitiated, they think, okay, I'll just get a wheelchair off the internet and it'll be fine. 2 wheels, a seat. What else do you need? But there's a lot of components that you need to think about. And so, I said earlier, I don't have any incentives to get you to do anything, but I do, in a sense. I'd like you to take advantage of our seating and mobility clinic that we have at KU if you have any seating needs. I'm actually not providing any care in that clinic because we've had to have a new provider that really has a passion for this and likes to do it full time. But it's a great opportunity to come in, have a physician examine you, have a therapist examine you, do all the custom measurements for you. And then we also have a wheelchair vendor who's going to be the one that's actually going to be helping with the ordering and the fulfillment of the actual wheelchair. And so it's really a great place or a great opportunity to come in and have multiple professionals custom build and design a seating solution for you. And unfortunately, insurance will cover this for a lot of folks who are really limited in their mobility in the home. So just, again, some different considerations that you might not think of if you're buying it off the shelf. You want to make sure that your back height is appropriate so that you're maintaining your posture. That being said, we want to make sure that we're having adequate support on the sides. So that's why sizing is so important. If the chair is too big, you're likely to be slouched over to the weak side, and that can cause a lot of issues. We want to make sure the seat itself is the right depth. We want to make sure it's the right cushion so that we're not having any skin issues. When we're talking about the seat itself, or I guess the backrest, we want to make sure we have the right flexibility. And by that, I mean, some of these chairs will tilt back in space, some will recline. Those are really important features when we're talking about patients who have potential skin issues and will need to use these chairs as they're performing what we call our ADLs, or bathing, bladder management, things like that. We want to make sure we have the right seat height for patients that do have good strength in their legs and they're able to propel themselves. We want them not just to rely on using their arms, because we can get overuse injuries with that, but we want to make sure that if we have a strong side, as we often do in stroke, that we're able to use that side to our advantage. So just some more food for thought here. There's a lot that goes into these wheelchairs that people don't think about, and why it can be so useful to have a team of professionals examine you and point you in the right way. Okay, and just some more considerations as far as what we do in our clinic. The examination I talked about, we write you a prescription tailor-made and specified for you, and then with our wheelchair vendor who does this full time, we can typically navigate with you and your insurance to make sure that we're getting you everything that you're entitled to, and also not on the hook for an exorbitant amount, because as we get into some of the fancier chairs, so to speak, the price can really get up there. Okay, and typically Medicare will cover 80% of these chairs if we have a documented reason and prescription for it, and then sometimes our supplemental plans will pick up the rest. Okay, and then just want to cover some emerging technology. So far we've been talking about pretty low tech stuff, just braces, plastic, maybe some lightweight metals, off the shelf gait aids, and then wheelchairs. And so we'll talk a little bit about some more innovative type of technologies. So a lot of you are probably familiar with the concept of functional e-stim electrical stimulation, so just or neuromuscular electrical stimulation, another term for it. Essentially, these are just electrical electrodes that are placed over a particular peripheral nerve and muscle to try and activate the affected muscle or joint. So stroke is a central nervous system injury. And so a lot of times the mechanism in which we are impaired is that our motor cortex, or the part of the brain that originates that message that's ultimately transmitted to the muscle, that how should I say, I guess the origin of that, of where those muscle commands come from, is the part that's damaged. But the peripheral nervous system, so the nerves and the muscles themselves, are intact. And so these types of devices will utilize that fact by bypassing essentially the whole central nervous system origin of the command, and just going straight to the peripheral nervous system, straight to the peripheral nerve that's supplying motor stimuli to the muscles, or straight to the muscle itself to activate. Okay. And so typically what we see, such as in this case, applied transcutaneously, so just over the skin. There are some actual devices that are implanted in the muscle itself, but these are primarily for research purposes only. And so again, just want to highlight that in this case, the electrical stimulation in conjunction with stretching and in conjunction with bracing or gait aids for that matter, is really the best way to go about it. And so there's been some studies that have shown e-stim in conjunction with stretching can decrease pain and range of motion in affected joints. And so cost of these things can range anywhere from $100 or so, and then this is a device that's actually a few $1,000s, more used in an acute rehab type of context. Okay. When we're talking about the lower extremities, there's actually two devices that have been developed and used for foot drop that that historically we've only been able to use the orthotics for, the foot braces. Okay, so one is called the walk aid, one is called the bionis. They're pretty sleek. Actually, this is the original. They've gotten even sleeker since, and lighter weight. But essentially, this is a device with electrodes and sensors within it, and the sensors can actually, they're three-dimensional, can pick up the the action of the entire remainder of the limb, and it's placing it in space. The activation is of what's called the fibular nerve that runs along the lateral aspect of the leg, and that's the nerve that's responsible for this foot being picked up, or if we have injury to it or to the part of the brain that's sending a message to the foot, then we're going to have that foot drag and drop. So the electrodes are actually going to activate the nerve along its course, and then enable us, in conjunction with the sensors, to activate when it's most appropriate in our gait cycle. Unfortunately, the cost of these things is pretty prohibitive for a lot of folks. It's in the $4,000 to $6,000 range. We hope we'd see these decrease over time, but unfortunately haven't really decreased all that much. That being said, in certain circumstances, you can apply for some additional financial assistance from the companies themselves. This is I didn't want to go too in depth into some of this equipment because it is so pricey, but essentially I found this to be a really good website. You can actually, this is Sabo, just one manufacturer of these devices, and you can actually point or click on the affected limb, and you can put in what your limitations are. So the shoulder, for example, you have no motion at all. You let them know, and that's going to point you in the direction of what some of the more appropriate types of devices are. And then as you have more function, you can indicate that, and then they can also point you in the direction. It's just kind of a good place to start when you're talking about, you have an affected joint or part of your extremity that's affected, just so that you know what's out there. And then, of course, myself or any rehab doc can help guide you as far as, really what might be most appropriate in your case. Okay. And then I wanted to talk just briefly about, some of the things we hope to see in the future. So this here is called an exoskeleton. It's really been used primarily in the spinal cord injured population, and it's pretty crazy. It's amazing, this technology. I've been to conventions and seen people walk with these, and they kind of look like Iron Man in these things. And so patients that really have relatively higher level spinal cord injuries and are completely paraplegic in their limbs can use these types of exoskeleton devices to regain their function and ability to walk. So if you can imagine how much this device is, right? This is $4,000 to $6,000. How much is something like this? These are typically in the $40,000 to $50,000 range. So not something that's really commercially available, but just an example of kind of these human machine interfaces that we hope to see in the future. And so implantable devices is something that's also being studied. I'll talk about that here in a minute, some of the work that's being done at KU. So, there's some exciting things going on. And then really kind of the hot new trend as far as rehab itself, not necessarily, an augmentive functional device, but something that's used in the acute and even chronic phase for rehab, is virtual reality. And so some of these headsets, the price of these has really decreased. And so you can get a virtual reality headset now for about $200. And so they'll have programs, actually. Sabo, this company here, has developed some programming that you can use almost as a virtual physical therapy or occupational therapy regimen. And so I hope we don't put any therapists out of business here in the future with these types of programs. But this is coming down the pipeline. It's already here, and the evidence is somewhat scant at this point. There's a lot of ongoing research in this realm, but I think it shows a lot of promise, because we talked about a device like this, thousands and thousands of dollars to do kind of occupational therapy, although this obviously provides some additional anatomical support, whereas a virtual reality helmet, it's just basically will be a pair of glasses that you can just slide over, bridge your nose, and can be transported to a therapy gym setting. So in addition to that human machine computer interface, we also hope to improve our materials. So orthotists are working on lighter weight materials so that the weight isn't interfering with our ability to move the affected limb. We want to decrease the price of these types of orthotics or devices, and also customize it specifically to the individual patient. So that's where things like 3D printers and scanners will come into play, and are already here, particularly in the pediatric population, where you can do all of your custom-made measurements with the patient with you in clinic, and then can actually submit the instructions to these printers, and at the end of the day, essentially have a tailor-made, custom-made brace for you. And then this is some of that stuff that may seem really far out there, but it's actually used for our Parkinson's patients, and these are deep brain stimulators. So again, this is in the context of Parkinson's disease, but may hold some utility in the future for stroke. But essentially, in Parkinson's, we have particular compartments of the brain, basal ganglia, substantia nigra, that are affected by the stroke. And the thalamus is kind of the relay station for messages from our brain to our periphery. And by stimulating with an implantable stimulator, we've shown that patients have really had some improvement, again, when it comes to Parkinson's. So ongoing studies for stroke, and so the evidence isn't there, the products aren't there yet, but something that further down the line may be an option. And then this is just a slide here to tell you about some of the exciting things going on in KU. So this is Dr. Randy Nudo. He's our lead researcher in the field of rehab. Essentially was at the forefront of understanding how different parts of the healthy brain can compensate for damaged portions of the brain or parts of the brain. And that concept is called neuroplasticity. Dr. Nudo was really at the forefront of that research understanding of that mechanism. And so he has multiple labs under his management. This is already a decade old. He was doing implants with rats, demonstrating improvement if we activate certain areas of that motor cortex that are damaged in stroke, and really showing some promising responses. Again, this was in rats, so far cry from humans. But he's progressed his research now to do some work on primates in his lab, and he's been doing a lot of work, not just for stroke, but also brain injury patients. So similar mechanisms of injury to our motor cortex. And so we'll see. It's an exciting area for sure. He actually, Dr. Nudo had developed a name of a company called Neuralink that was essentially interested in this type of research. And so the story goes that he got an anonymous phone call one day from someone who was willing to pay a substantial amount of money for the name. And so he says, yeah, sure, it's just a name, who cares? I'll sell it to you. Use those monies for research. And so later he finds out that it was actually a Elon Musk representative. And so Elon Musk has been doing some research with that company, Neuralink, has been featured lately in the news. So anyway, the future is bright. I know we covered a lot today, all the way from over the off the shelf, off the shelf stuff you can get at CVS. And now on this end of the spectrum, we're talking about implantable brain devices that you need a neurosurgeon to place. So, it's a big spectrum of devices out there. And so we're happy to help you find the right one for you. And so myself and any of my colleagues would be happy to see you and help you improve function. Again, that's word number one for rehab. So with that, I'm happy to take any questions or comments.